Have you ever done a chest wall block and noticed that the lung looks abnormal on ultrasound? Could it be a pneumothorax? In this video, we'll cover the flowchart on diagnosing pneumothorax from the International Evidence-Based Recommendations for Point-of-Care Lung Ultrasound. A pneumothorax is a collection of air outside of the lung but within the pleural cavity. It occurs when air accumulates between the parietal and visceral pleura within the chest. A lung point is a specific ultrasound sign that indicates the presence of a pneumothorax. It's the interface between the healthy lung and the pneumothorax where the visceral pleura of the lung separates from the parietal pleura of the chest wall. In normal lung sliding, we see the movement of the visceral pleura against the parietal pleura. This movement can be described as looking sparkly or like ants marching on a log. Because lung sliding is the movement of the visceral pleura against the parietal pleura, its presence rules out a pneumothorax. In this lung ultrasound, we see an area of discontinuity. Is that a pneumothorax? If we look carefully, we see lung sliding on both sides, so the whole lung is sliding, and in this case, this is a lobar fissure, not a pneumothorax. A lobar fissure is a double fold of visceral pleura that either completely or partially folds into the lung parenchyma to form the lung lobes. This is detected on ultrasound as an interruption of the pleural line and is a normal finding. Here we can identify a lobar fissure on a patient with chest wall trauma receiving a paravertebral catheter. So we see this area of discontinuity, but if we look closely, we see lung sliding on both sides of this groove. B-lines are hyperechoic comet tail lines that start at the pleural line and do not fade with increased depth. The presence of B-lines proves that the visceral pleura is opposing the parietal pleura, excluding a pneumothorax at that point. One or two B-lines in an intercostal space may be normal, especially in elderly patients at the lung bases. It's considered abnormal when 3 or more B-lines are identified in an intercostal space. In this pregnant patient with HELLP syndrome, eclampsia, and pulmonary edema, the fluid-filled lungs create multiple B-line artifacts that resemble disco lights. On this lung ultrasound on a child with COVID pneumonia, we see this area of discontinuity. Is that a pneumothorax? We can see lung sliding on both sides of this groove and coalescing B-lines from a subpleural consolidation, ruling out a pneumothorax. We mentioned earlier that a lung point is a specific ultrasound sign that indicates the presence of a pneumothorax. So in this video of a serratus anterior plane catheter, we clearly see a point where there's absent lung sliding adjacent to normal, healthy lung sliding. Is this a pneumothorax? If we look closely, we see the diaphragm, which appears as a thin hypoechoic muscle between two hyperechoic layers, the peritoneum and diaphragmatic pleura. This represents a physiological sign that mimics a lung point but is not a pneumothorax. Anatomically, there are 3 areas that mimic a lung point: where the right lung contacts the diaphragm, where the left lung contacts the diaphragm, and where the left lung contacts the heart. These physiological signs differ from a pneumothorax lung point in that soft tissue can be visualized in the no-lung region. In a pneumothorax, the no-lung region shows an A-line pattern without sliding. A-lines are a type of reverberation artifact that appear as horizontal echogenic lines on lung ultrasound when the ultrasound beam interacts with air in the lung alveoli. These lines are equidistant from each other and appear to fade as the depth increases. The presence of A-lines in lung ultrasound usually means that the lung is well aerated, but they can also be found in pneumothorax when lung sliding is absent. What do you think of this lung scan where you don't see any lung sliding? Is this a pneumothorax? If you look closely, you'll see the rhythmic movement of the visceral pleura on the parietal pleura with the cardiac auscultations, also known as a lung pulse. The presence of this cardiophasic movement of the pleural line indicates that the visceral and parietal pleura oppose one another, and so its presence rules out a pneumothorax. In the case of right mainstem intubation, on the left lung we would see lung pulse without sliding as we do in the scan. To summarize, a lung point is a highly specific ultrasound finding of a pneumothorax. In extreme emergency, absence of any movement of the pleural line, either horizontal lung sliding or vertical lung pulse, coupled with the absence of B-lines, allows for prompt and safe diagnosis of pneumothorax without the need to search for a lung point. Lung ultrasound is more accurate than chest X-ray in ruling out pneumothorax with a sensitivity of 88% versus 52%. Use of lung ultrasound to diagnose a pneumothorax and guide life-saving therapy is essential, particularly with unstable patients and resource-limited areas.